Hello everyone, this is Mary Gregory. Welcome to Mass Coding TV and the Medical Coding Lounge, where coders come to learn, grow, and connect. Today our educational session is going to be on Z codes. Do not snooze on Z codes. There's a lot of myth about Z codes, coding, and so today we want to clear up some of those myths about Z code coding. Z codes are found in chapter 21 of your ICD-10-CM book. Why do we have Z codes? Z codes are used for coding health statuses. We are coding conditions that can influence the health of someone. They are not used for when a patient have a disease or a condition. And so they are we're using these for a reason, for encounters other than disease or injury. And you must remember this. For some reason, people have a tendency to do this. Z codes are not procedural codes. Z codes are diagnosis codes. And so if someone come in and they have a Z code, but they also have a procedure, you will need a procedure code. Now, of course, if you're inpatient, you're going to have a PCS code. If you're outpatient, you are going to have a CPT code or HCPCS Level 2 code, depending on what the procedure is. So why do we use Z codes? Well, we use Z codes to provide clinical context. When someone comes in with a condition, there may be some other clinical context that can help identify this patient, what's going on with the patient more accurately. Of course, you're going to find your social determinants in the Z code section. And the social determinant codes now really need to be used to help identify risks. Some of the social determinants codes can increase reimbursement, risk adjustment. Not all of them, but some. But we can collect these social determinant codes to show the risk of the patient. It may show the risk of the patient being readmitted. A lot of times when I have coded or worked on audits, patients that are homeless tend to have a lot of readmissions because they're homeless. They don't have anybody to take care of them. And so and because we have this readmission quality review that goes on with CMS, you're going to capture those social determinants that could cause your patient to be a revolving door to come back more often than someone that's not. Your Z codes support quality reporting. So once again, CMS have a quality report that facilities and maybe even physicians have to do, especially in value-based reimbursement. So some of these Z codes can help explain and support quality. They can also help justify medical necessity and utilization of the services that is being provided by the facility. Now, in your chapter 21 in the code book, it started out with Z00 and it goes to Z99. These are broken down by sections. And so some of your most common one, of course, is screening, follow-up. And we're going to talk about some of them very specifically. If we don't get to do it in this video, we'll do it in the next video. Aftercare and follow-up codes. And they all have some additional coding guidelines. Now, some of them are very self-explanatory. Say, for instance, if someone is confined to the bed, you have a bed confinement code. That's very that's very easy. That means this patient is bedridden. And so you have a code to indicate that the patient is bedridden. And you might say, well, Mary, why is that important, especially in inpatient coding? Because once again, they are going to utilize more nursing services when someone is bedridden. That nurse is going to have to do everything for the patient. Personally, I have a personal experience. My mom was a bedridden patient, and when we had to take her to the doctor, we had to have an ambulance to do it. That's something that was covered because my mom was a bedridden patient. And so it's really, really important that we capture these Z codes. The Z codes can be principal diagnosis and they can also be secondary diagnosis. CMS have a list. If you go to the official coding guidelines, of course you can Google this as well, but if you go to the official coding guidelines in Google, if you want to Google it, or in your book, when you go to the official coding guidelines, there's a list of the ones that can be principal diagnosis, and generally should be a principal diagnosis only. However, there may be times when it can be a secondary. And then you have some that's always going to be secondary. They should be never principal diagnoses. Now, some of you out there, you might work in a physician office, you might work in the outpatient arena. It's very hard in the inpatient setting to have a diagnosis that's not acceptable as a principal diagnosis because we have coded software. And if we put a diagnosis in there, and it doesn't have to be a Z code, it can be another type of diagnosis, because some of the other diagnoses generally should not be principal. And we would get an edit to say, this is a diagnosis that should not be principal. Would you like to review? Maybe in the outpatient setting, you may tell me, well, Mary, we have used some of these diagnoses as principal that should only be secondary, and we never had a problem. Well, that's because we don't have a coding police, okay? There's no coding police coming after you sometime when you code stuff wrong. Sometimes, have you looked at your denials? Sometimes denials occur because you did code it inappropriately. But once again, it just depends on your education level. If you're following up on these denials, some people just write them off rather than saying, you know what, did we code this appropriately? With me saying that is this: there are insurances, there some Medicaid program that will say, well, we don't want a Z code as a principal. However, there are times when the Z code is truly the principal diagnosis. A while back, we had several ER cases where the patient was brought in to be, they had been in accidents and they was going to be arrested, and so they brought them in for an examination before taking them to jail. Well, you have a code that says examination for prison, but that can include jail, it can include juvenile detention centers. There's further explanation as to what this really covers. It doesn't just cover a jail, but it can be a prison, it can be a jail. Well, we got a denial saying, you know, this cannot be a principal. But that's truly why the patient came to the ER. And so I'm not exactly sure what they did in the billing department. I think they decided to file if the insurance says not covered, then sometimes we just can't do anything about it. Of course, you can appeal, but just remember, Z codes can be principal diagnosis, and in certain cases should be the principal diagnosis. For instance, if a patient come in for a colostomy closure, I think that code may be like Z43, somewhere in that category. Well, that is considered to be follow-up care because the patient had maybe an obstruction and they had to create a colostomy, and now they need to take it down. Or, hooks the two ends back together. They don't need the colostomy anymore. Well, that's an aftercare code. And so that Z code is very appropriate as the principal diagnosis. We have patients that come in because they have a VAD, a vascular access device, that need to be removed. And so, once again, that's the principle. That's why they came in. They had the VAD removed. And so there's going to be times when you're going to have some Z codes as principal. I can think right off. Now, there's some Z codes, like I said, that can't never be secondary. And you might say, what? Yes. For instance, Z38, newborns. Z38 can never be a secondary diagnosis. It's always a principal diagnosis because anytime you're coding a newborn baby delivered at your facility, it's a Z38. If the baby has to be transferred to another facility, the receiving facility cannot use a Z38. And so the Z38 is one of those codes that can never be a secondary. So watch out for that. We know that we can have a principal diagnosis for anti-neoplastic treatment, your chemotherapy, your radiation therapy, your immunotherapy. These are very appropriate as your principal diagnosis, and they are Z codes. Now, also too, in dealing with your documentation, we have a few documentation tips for you. Number one, you always have to clarify a screening versus a diagnostic. It is very, very important. You also have to differentiate aftercare versus follow-up care. Very, very important that we do that. Also, too, when appropriate, you want to capture your social determinants codes as well. In the state, I want to say in the state of South Carolina, I did a little bit of coding there. The facilities there encourage and receive additional reimbursement for their social determinants codes. And I believe it has to do with homelessness. So we are, and it might include more than that, but we have to look to see if there are some social determinants that we need to pick up. If you work in a facility, if you work in a physician office, it's important for you to capture this information. And maybe you want to have a very specific place in the chart where you can find this information. A coder has to code so many charts a day, and because of that, we don't always have the time to look all over the chart. So we need for whoever's in charge of documentation to encourage the physician to put it in one place, or if per the coding guidelines, we can actually capture social determinant information from like managed care, from the social worker. And so once again, just make us as coders aware of where the diagnosis can be found. That's the reason why we miss it a lot of times, because we don't know where to go find it at. And so that's one thing you need to have in your coding guidelines, where to find these social determinants, Z codes, documentation. So now let's break down. So we talked about why I use Z codes. Z codes are important for you to use to help paint the picture of what's going on with the patient. They can be principal diagnosis. It's a fallacy out there that they cannot. Yes, they can be when they are responsible for the encounter. They can be principal. We generally don't have a lot of Z code for inpatient principal diagnosis. Now, we could have one, like I said, someone could come in for a closure, for their colostomy closure, develop some complications, and wind up being an inpatient in our facility. So watch out for that. Always make sure your documentation is supporting what you're coding. So that's going to end this part. So I guess this is going to be part one, because part two we actually going to dive deeper into some of the most common ones we see and some of the coding guidelines that goes along with that. Okay, don't forget to follow me on LinkedIn, Twitter. Yeah, we're on Twitter, I think. LinkedIn, I know we're on LinkedIn. I know we're on Facebook. I'm doing TikTok as well. Our website is www.mascodingsolution.com. Look, subscribe to the channel. Like us. If you getting any good information out of these videos that we bring you, then like them, subscribe. And we'll be on the watch out for more for a PowerPoint that's going to be put out later on this subject that will encounter both of these that we're going to be doing today. So look forward to talking to you soon about part two. Do not snooze on Z codes.